The landscape of gastroesophageal adenocarcinoma is changing rapidly. We know about HER2 as sort of the first one introduced into the disease, accounting for about 10 to 15% of patients. And now, more recently, we've learned of molecular groups that render sensitivity to checkpoint inhibitors like PD-1 and PD-L1 inhibitors, including biomarkers like MSI high and high PD-L1 scores, potentially high tumor mutation burden. And so in addition to that, the landscape may change even further in the near future, including we talked about bemarituzumab or BEMA with FGFR2 amplification and or overexpression of the protein. And so that based on the phase 2 study that we reported at ASCO this year, for updates, we're planning a larger phase 3 study. And so hopefully this drug will be able to get to patients sooner rather than later. In addition to that, there is claudin as a biomarker. Claudin is a tight junction protein that is overexpressed in various cancers, including gastroesophageal cancer, and a monoclonal antibody, Zolbetuximab, that targets that. Has shown a benefit in a randomized phase 2 study, the FAST study, and now there are 2 large phase 3 studies being evaluated, GLOW and Spotlight, evaluating that in prospective fashion globally. So those have been open for some time, and so hopefully will accrue fully and we'll see results and potentially could change the standard of care for claudin high tumors. And then also there are a couple of other genes like MET and EGFR that do also have gene amplification, just like FGFR2 and HER2, and they also have targeted therapies that are directed towards them. And so each of those being around 5 to 10% of the whole of the patients. And so again, for those patients, targeted therapies towards those genes make sense. And so that you can see that slowly the disease is being subdivided into multiple different subgroups. And the other important thing to note is that there is some overlap now between each of these biomarkers, and a given patient's tumor may have more than one. And so that now we've gone from the setting of not having a lot of choices to many for the same patient, which is a good thing to have that choice in, but we're going to be faced with having to prioritize these treatments to say which is the best one for them. And then the landscape going forward may be combining the targeted therapies in that particular scenario to sort of do even better in terms of outcomes.